We can get the slides queued up for the next presentation. I think, are we ready for that? Wonderful. Next one. There we are. All right. All right. Welcome back, folks. Appreciate your being here with us today, and I hope at least some networking. I know I got a few connections made and some follow-up items now on my to-do list. We're going to return to the topic that we started out the day with in terms of collaboration. And you're going to have an opportunity here. Let's get to the next slide again. Go ahead. We'll get to the title slide of the presentation. Collaboration in the, there we go. Collaboration success when facing funding constraints. Want to be able to share with you an example. We have with us today Raquel Garcia, who many of you know, Chief Innovation Officer with Heart Beauty, and then Camille Harding, for those of you who may know Camille, previously with Healthcare Policy and Finance, and then the BHA, and then also before that, Office of Behavioral Health. These two are going to share a little bit the experience of what they were able to do to identify strengths that they each had that they could combine in order to create some success at a time when perhaps things could have gone south in a not so good way, and what that means. But they're also going to offer you the opportunity for some conversation. They'll explain a little bit more. You got some paper on your tables here. I want to give you an opportunity to be thinking about this as well. What does this mean for you? What kind of situations are you in terms of thinking about your partners in the community? What could be the potential, depending on where things go? And I just want to remind folks that we've been here before in this field of work. I mean, we've never really been overly funded for behavioral health or for substance use disorder. We never have. It's always scrapping around for the funds. But those of us that went through the 2008 economic downturn, we came out of it. One of the groups that did really well was Illuminate Colorado came out of that one. It's like all these folks that were dealing with pregnant parenting women and drug endangered children found a way to kind of pull together. A great example of how that collaboration strengthened them. And here they are still here almost 15 years later. It's like still here. And then we went through it in COVID, right? With the troubles we had there with the funding, et cetera. Now, perhaps it looks like we're in another situation. And my sense is that we're going to come out of it again. And my hope is that people come out of it stronger, not weaker. So with that, I'm really pleased to turn over to two individuals who will introduce themselves further and lead us in our next session.
Well, good afternoon, everyone. How was lunch? Yeah, we're going to try to liven this up a little bit. No, I'm just kidding. This is not that. Well, it's me, so you probably will get a little something. First of all, I just want to say thanks for taking the time or taking part of your afternoon to spend some time with us. Heart Beauty, we were a very, very grassroots organization out of a town. We were born in a town of 2,200 people in Palmer Lake, Colorado. Most people don't even know where that is. Anyone, how many of you know where Palmer Lake, Colorado is? Oh my gosh, that's so amazing. That means most of you have been to O'Malley's. Yeah, Tiffany, give it up back there. She used to be the bartender. But we came from very small beginnings, right? Tiffany and I both starting Heart Beauty. And it's the reason why we actually exist and why Camille and I ended up hooking up was actually thanks to the Stedman Group and JK. Not knowing a whole lot of nothing about behavioral health, I just know how to help people who are struggling with a substance use disorder. I didn't know anything about the professional aspect. I've learned so much in the last 7 years, more than I ever thought could be possible. But we found ourselves at a crossroads about a year ago. Declining in funding and really stressing ourselves out with how we are going to continue. And some of the programs we work with and services we provide are pretty critical. And JK had helped us out, and he said, hey, I might know this person. You might check out Camille and check out Paragon Behavioral Health. Because when I think about you two individually, when I think about what you are doing individually, organizations, when I think about y'all coming together, that might be kind of amazing. And so I first wanted to just say thank you to JK. Are you in the room, JK? I'm like, goodness gracious, JK. But JK saw both organizations as innovative practices and both of our leadership styles and thought we would make a good match. So I kind of wanted to start off by saying thank you to JK. Is he walking in the door? Nope. Oh, it's Allison. Hi, Allison. But yeah, that's actually how we got connected, is someone saw something in both of us and put us together. All right, Camille.
Okay. Can I stay?
Oh, yeah, they're yours.
We're sharing notes because we're that organized. Okay, so I'm going to just talk a little bit about why we said yes. So a little bit about Paragon. I started Paragon after leaving state government for about a decade. I was in state government in a variety of capacities and started Paragon with the intention to fill gaps in the continuum of care for folks that have high acuity and more complexity. I wasn't interested in sort of doing routine outpatient services. That's not really the space that we need more coverage and support. So started Paragon and stood up with the help of a bunch of support from the RAIs and the BHASOs to really think about how do we deliver care in a way that's meeting needs of those that have comprehensive and or intensive needs for services. And so, long story short, JK approached me and said, "Hey, do you know Raquel?" And I was like, "I do not know Raquel, but I've heard a lot about her." He's like, "Let me do an introductory meeting." So the rest is sort of history. I thought the way that we're really thinking about delivering services as an organization, as Paragon, is really how do we offer complementary services, layer in the clinical services as appropriate and as is needed, and really think about, right, this is Raquel's term, ecosystem. And so we had done this with a few other organizations where essentially we partner, we think about how do we align treatment plans, how do we deliver services in a way that allows folks to choose their own clinical pathway. It doesn't have to be clinical, it could be peer support, and sometimes it's both. And we align treatment plans. And so it was really the meeting with Raquel, we were like, how can this look? And I think that there was a lot of alignment around mission, vision, purpose, and really around delivering services to folks that need clinical pathways that are appropriate for them, or pathways. I keep saying clinical because, right, like that's my background. We're learning to work together. And the other thing is that the system is really fragmented as it is. So historically, mental health system and then substance use system were not combined and aligned. And I think this gives us an opportunity to really align those systems in a way that makes a lot of sense. So if someone needs a higher level of care for clinical intervention or suicidality, right? There's a really easy way to pass someone that's receiving peer support to us. We do a set of interventions and then pass back. Sometimes we're like, gosh, we can continue both of us serving an individual or a family. And truthfully, there's a lot of alignment around, I think both of our organizations focused on serving moms and caregivers with littles. And we do a lot of child and adolescent work and a lot of family work as like clinical practice. About within our organization, 60% of our open charts are children and families. And so there's a lot of just sort of strategic alignment in terms of the populations that we're interested in serving. And so long story short, we were like, this sort of works, and we are iteratively working through making it functionally streamlined and operationalizing all the things that we can do to make sure that there's fewer barriers for folks getting the set of services that they need.
Why we said yes, or why I said yes. It wasn't just a me either, right? The reason I said yes is, I'll be very honest, Heart Beauty was gonna have to shut down 50% of what it does across the state of Colorado, including pulling out of every single hospital that we serve. We service 14 hospitals in the state of Colorado, where we respond bedside to mamas who are struggling. To this day, we have seen 65 babies being born in this state, 65 babies. We have prevented Child Protective Services from removing child from home or from mother 94 times. Just last week, we had 3 babies born in Colorado, and we do this work in Grand Junction, in Glenwood Springs. We respond in Denver, at Denver Health. We respond to every and have a contract at every single Intermountain hospital in the state of Colorado. That's what is my reason. I can't imagine a world where I don't get to go bedside to mamas. Not only that, but I employ 21 women who are in active and sustained recovery who are moms. One of those moms on my team is classified by background as a violent felon. She pushed wheelbarrows for 10 years because it's the only job that would employ her. Today, she has seen 7 babies being born into the world. She is a recovery doula. If you go to parole in Colorado Springs, she's there every single Thursday. I couldn't imagine a world where I didn't get to employ Candace. And I'll be honest, I was desperate and very scared. We were losing a huge amount of funding. Medicaid, we had gotten robbed by an organization which put us set us back with no assistance or support. And I didn't know what to do. And before JK had approached me, I sat in my basement. I just talked to my staff this morning. Do you remember when we sat with the dry erase board and we said, what do we save and what are we going to have to let go? How many of you have had to sit at a dry erase board or make those decisions before? It's the worst feeling in the world. But if you know me, I don't give up easy. And I was determined to find a way. And JK had watched, and we were doing this great work, and he said, Raquel, for the exact same reasons. Look, you do this mom's work, you do great work all over the state, and we're a peer recovery coaching practice, right? I am not clinical in any way, shape, or form. And we do bill Medicaid. And so what Paragon offered was an opportunity for us to stay alive, keep my people employed, still serve moms. Those 3 babies last week are because we became a partner of Paragon. And we do services not just in the metro area, but we service all the way in Alamosa, Colorado. We go to the places. I just got a call from a judge in Baca County. We go where nobody wants to go or will go. And not only do we believe in making sure that people get services, but actually employing and not contracting a peer workforce who gets health care and time off. My mamas work really, really hard. And that was really important to me. And I did kind of stalk you. I stalked you for good things because I didn't do that in the beginning of my career. I took everybody at face value, believed what they said, and it wasn't to the advantage of my workforce or my team. And so I did stalk you a little bit. I've been stalked a few times myself, I'm sure, to find out that we were in alignment. We have a great passion for the most marginalized populations. We don't believe in just servicing people, but taking good care of the people who take care of the people also. That's something we align with. We align with making sure that we help vulnerable populations in rural communities. Camille serves 26 counties. We serve all 64 in the state of Colorado. We were funded as the first virtual peer recovery coaching practice right after and during COVID. I said yes because Camille is very similar in nature as a leader. And that was really important to me. And I also said yes because she wanted to partner and not monopolize me. When we're struggling, it's easy for me and someone to offer me to buy me out or to take over what we've created, but that's not what Camille did. And as a woman of color, that was really important to me. That someone didn't just offer to opt and buy out everything that we've worked. And Tiffany back there in the back has worked our asses off for 7 years. And we didn't get bought out. She could have said, hey, I'll make you a deal. But she didn't. She said, no, you're really good at what you do. we're really good at what we do. And why don't we just do this work together? And so that's why I said yes. That's why I said yes.
Okay, so we're going to talk about you. Am I supposed to do this?
We haven't planned, we did not have plans. Well, we have not,
started it.
yeah, we planned it, but we did not practice. Yeah.
Okay, so part of why we think this works is because I think Raquel's mentioned this, is there's a lot of values and alignment around our mission and vision. And organizationally, I think we have really intentional work around being person-centered. I think part of the reason that our system really struggles, right? It's fragmented. And also, we don't do a great job. We talk a lot about person-centered care, but I don't think that we actually do a great job of being really person-centered, right? It's really easy to say like, great, I'm going to do your assessment and get you into treatment the minute someone comes through the front door, and there's rules that require that we do that. But at the end of the day, right, someone might not want a whole assessment. We do it anyways because we have to follow the rules.
You can also.
And also, and also, if someone walks through the door and is like, the best place for me is to start some outreach and engagement or some peer support services, or I really need a medication refill, we try to accommodate that and then sort of do a lot of motivational interviewing and talking about like, what does your care pathway look like to you? And sometimes we have people come through the door and they're like, I don't want to see a therapist. I just want family therapy. I don't want this. And then we will pass to other organizations or partners that make a lot of sense to them.
I was going to say too, I think the ecosystem piece, I talk in a lot of medical spaces and clinical spaces where you forever have been the gateway in to get the thing, the service, the support. We're flipping the script. Why can't we be the pathway that they get to you? I think we are, and I've experienced that we are the way that they ask about medical care. We're the reason they ask about clinical support services. We're the reason they get into treatment, right? And so kind of thinking of this ecosystem a little bit differently, that there could also be multiple pathways to entering this ecosystem.
The other thing I would say about that is that in terms of sort of a footprint, it allows people to really sort of have a flexible model of care that really matches what they need. And so we spent last Friday really talking about hours upon hours, talking about aligned treatment plans, right? Or care plans. And how do we both have collaborative pieces of that when there's probably a subset of folks that need both sets of services. It doesn't mean that they just have to get treatment and then I pass off to Hard Beauty, or Hard Beauty's like, oh, we really think you need clinical. There's instances in which we can really have a plan of care that aligns and they get both things.
It's working too.
And it does work.
Yeah.
Yep.
It worked.
What else?
So the other thing we talk about is equity-driven leadership and cultural humility. Both of us have a deep value for that, even personally and as an organization. Leadership that listens first, learns continuously, and shares power, walking beside communities with respect and accountability to ensure every voice, especially those most marginalized, help shape the systems that serve them. So I'm going to look very different in Alamosa than I do in Castle Rock. I'll tell you that. That's a totally different experience. Yeah, I know, right? It's so different. Castle Rock or Douglas County, the healthiest, wealthiest county in the state. It's the motto that they go by. I live there, so I'm not talking about my own community, but it is very different where how we'll enter that community versus how we approach in Alamosa. Where we are in Glenwood Springs is very different. How it will be in Baca County, and we both believe that those communities should drive what best suits them. So I've been embedded in Alamosa region, the San Luis Valley. I fell in love with Alamosa at a COAC conference. Actually, the Attorney General and Lori introduced me to some peers in that region. And in that region, a majority of the peer workforce is Hispanic. That'll look very different than this side. But they don't have any people of color to lead. And so I've been working a lot in that region. I actually now employ 2 people in the Alamosa region where we are working really hard and letting them build it. I tell them, look, I'm the vessel. Hard Beauty has a vessel and a platform and maybe some access. It's still your community. I can't speak for Alamosa, right? And so also creating leadership within communities, right? I had women tell me, Raquel, nobody's teaching me how to lead, and then being mad that I can't. I said, well, I'll teach you. We can, figure out your pathway of learning. So I think that's really important. And then we both believe that everybody, equitable access for care. I just don't, we both deal with Medicaid, so barriers, we'll talk about that part later. But people should have access to the care that they want. We talk about serving marginalized and rural communities, both of us. I actually grew up on this side of the divide and grew up in Aurora. But with my opportunity to, honestly, with Dr. Stater touring the state of Colorado, I visited 28 hospitals in the state of Colorado, sat in all of their labor and delivery spaces, and I just saw huge gaps in the rural communities and fell in love with parts of Colorado that I never even had experienced myself. And I actually, grew up in the Aurora area. I live in a small town. It's Palmer Lake, but when you get there, I don't care about anything on that side of the divide or that side of the divide. And I live in a town of 2,700 people. I actually live in the Larkspur line, but I own a cafe and have raised my children in Palmer Lake. So that small little community is that's also where I got sober. I did not find recovery in the city. I found recovery in a town of 2,200 people. So most of the things that I'm passionate about also are tied to like my own experience. I got sober, actually graduated from Parker Valley Hope, actually. I'm alumni from that program. But when I got released, this is way before peer support, it was like a yellow folder. I actually still have the folder and I'm gonna show it to you one day. It's so great. But the yellow folder that I got from Parker Valley with a bunch of numbers. That was it. And slingshot me back and hope I make it is the worst plan. And I went back to a using husband for 8 years. And a lot of people in rural communities, that's the struggle, is how to embed yourself back in community. That last one's you.
Yeah, so the last one is really a commitment to quality care. One of the things that we really think about is what is that care pathway? And we don't need to hang on to everyone for forever. We have a evidence-based suicide prevention model that we follow that has really good sort of reduction in suicide and readmissions and all the things. And it's a brief intervention, 4 sessions, and then we can offer that, right? If we identify someone or Hard Beauty does, or any of our other partners identify someone that has suicide risk, we do that intervention. We can do it telephonically. We do it in person. Our models really doing stuff in the homes. 90% of what we do is in homes. And then what's next? And sometimes that's peer support. Sometimes there's other interventions, and we don't have to hang on to everyone, but we really think about targeted interventions that are going to address what is the thing that is the biggest deal for that individual or that family. And we try and do it with integrity and make sure that some folks really want long-term services, and we will hang on to them. And when people are ready to step down into other pathways, that's great. We're going to send them there. And I think that there's a lot of alignment in sort of this thinking about like, how do we support people and build community? Part of our organizational mission is to build community. And it doesn't mean that you're going to have a relationship with your therapist for the rest of your life. It means that we're going to help you find that community and pass you into sort of the next set of things that are going to make sense for you. Sometimes that's ongoing peer support. Sometimes that's, I found a volunteer place that I'm going to hang out and I feel connected to, but it really is about people building connection. It isn't about sort of long-term therapy for the rest of your life. I love therapists and all, but they can also be kind of annoying as a therapist. As a therapist.
Well, I like when I hear you talk, I hear the and, right? Some of our most successful clients are ands. If I can look back at my own experience as someone who went through therapy, good God, I could have used a coach. wondering why I could never progress forward. And I felt like I was always in the constant swirl. I really needed someone to, yes, address the things that brought me to the moment that I'm in, but also help me get from where I'm at to where I want to go. And that's what's beautiful, right? We can actually work those things at the same time. And some of my most successful clients, this is a young girl that was actually before I went with Paragon. She was in Woodland Park, Colorado. I spent a year and a half never actually meeting her in person. Her therapist actually had her contact me and say, I think you should contact this coach. You know, therapists have a list of things they want accomplished. Her mama had a list of things she wanted her to finish. I didn't work on any of those. I actually asked her what she wanted to work on. And she did have a clinical she was clinically diagnosed with obsessive compulsive disorder. But that's not what I worked on. She has a therapist for that. You know what she wanted me to work on? A boyfriend. Do I quit band? How am I going to graduate? I'm obsessed with Instagram. I need to get off. That girl is on her third year of college, you know? And I got her when she was like a freshman in high school. It's wonderful. And I still get to be a part of her life. And she's had 4 other therapists since then. But I've stuck around, right? And so peer support is very different. And I love the and. When someone does talk to me about clinical, you know, I always say this even to my coaches. If I'm working with somebody and we have talked about the trauma of your past, every time we have a conversation, I might have to say, hey, Sally, every time we come into a session, we keep talking about the trauma of your past. And I've got to be very candid with you. That is not where I live as a coach. But I have a great organization now that we partner with. And you could get services for that too. And it's really cool to see now, because we didn't meet our teams last week, to start seeing, because we can see how many people are receiving peer support services and the clinical services. Who's doing some of our clients in our area were on wait lists to be able to see services, right? And if they can't get into a therapist right away, guess what? We could be a coach in the meantime, right? So I think it's that and piece. And I'm just seeing that, and I loved seeing the numbers last week. It's kind of the first time we really looked at some of those things together. But it's really neat to see that how we're be able to support each other and teams supporting each other. I feel like, you know, we always talk about the people we serve. This work is hard and holy work. This work is hard. It is challenging. It is the greatest work of my life, but it is hard. And we can hold 2 truths at the same time. And I want some support. Camille knows the things about Medicaid, y'all. That has been a whole new learning curve. I was a recipient of Medicaid. I didn't have to learn it from the other side up until about 5.5 years ago. So Camille helps me become more knowledgeable and learning. And then we get to see these commitments to long-term care. Like I said, that girl's still in my life. So I'm excited to see, as we grow, to see that continuum of care. And it's always like, come back. Like you said, you don't have to be here forever. And if there's a life event that challenges you, come back. All right, you guys get to participate now. In middle of your table, so you can grab a sheet of paper. I wasn't sure how many, I definitely did not print enough. But there should be an example at every single table. Yes. There should be 1 per table. Sorry, I have to see one to look at. I should have printed more. Here's one at this table back here nobody's using. Welcome to the trainings with Raquel. You can't even get an MI training without writing some down with me. I think we often come to these things and do a lot of listening. And I kind of want to do a little bit of doing. So when we think about an ecosystem, I'm actually going to kind of jump ahead on my slide, just so I can show you the ecosystem of healing that we want to create, right? And we're still growing this idea. We feel like it's clinical care, peer recovery support, MAT referrals and partnerships. It's bicycle health for rural access. That's who we have to use in some of our spaces, only place I can get people Suboxone. Hospitals, justice and reentry programs. Hard Beauty actually is inside 14 facilities across the state of Colorado. Community organizations, recovery groups, in-home and family support services. So we're thinking about all this in an ecosystem. And so I kind of wanted you to think about that for your own selves. You know, we are in challenging times. Hard Beauty lost $250,000 in funding. That's a big hole to our work. especially considering not only do we help the most marginalized, but I also employ the most marginalized people, right? We have a lot of vulnerable population that are thriving in employment sometimes for the very first time in their lives, right? That's a vulnerable spot to be in. So I want you to think about alignment for yourselves, right? The way we're going to get through this, I truly believe, is not by competition, it is by collaboration, right? I know my strengths, Camille knows her strengths, her organization knows their strengths, our organization knows our strengths. And so I want you to think about your organization's core, your mission, your vision, maybe the primary population served, and write those down. And you don't have to know your whole mission statement. I don't need your whole vision statement. Just what is your mission and your vision for your organization? And write that down. And then, sorry, y'all, I should have put it on slides. I didn't. And then the primary population or people that you serve. You know, when Hard Beauty did this, we thought we serve families, lots of perinatal mamas across the state. We work a lot with currently and formerly incarcerated individuals. Who do you work with?
We work with lots of moms, lots of kiddos. We do lots of prenatal, postpartum care. And we work with lots of folks that have serious mental illness, a diagnosis of schizophrenia. And we do lots of crisis support. We actually have the crisis contract to take dispatch from 988 in 6 counties and that are rural in particular. And so we do a lot of crisis and after hours coverage for anyone in our ecosystem can call as well.
Well, and I love this because when we go back and forth, you'll start hearing the alignment between the two of us. And I want you to think about that for you and the people that you work with. So the service lines that we provide, ours is pretty easy. Peer support services is what we provide. We actually provide peer support services, and we also provide trainings. Hard Beauty is one of the training organizations for the state. So we also create and help educate and train peers in the state of Colorado. So those would probably be our primary lines. What are your service lines or what do you offer? I know, just keep it on.
I keep turning it off because I'm like, you don't need to hear me breathing. We do, I think I just really named them, but we really think about sort of those targeted clinical pathways that are focused on what it is that the individual needs. So we, of course, have medication management and a lot of intensive family therapy that's sort of multiple times a week with families that are high risk for child welfare involvement or are in fact child welfare involved. And then we do lots of crisis.
Yeah, and so for those service lines for us too, also, like I say peer is very general, but we actually have a program called Operation Care. And Operation Care actually is a response program that responds bedside to the hospitals. So we get a call in. I was about to say 8 days a week. There's not 8 days, Raquel. I almost said 8 days a week. It does feel like there's 8 days. Look, everybody's nodding their heads. 7 days a week, we answer from 8 in the morning until 8 at night, and we can respond same day or next day. We'll also be the peers going inside Skyridge Hospital to start there, also labor and delivery, and also in the emergency room. And so those are kind of in that matches, right? Because you're doing mamas, we're showing up bedside, great alignment there. So geographical focus. What's your geographical focus for your organization? Camille?
We're in 26 counties, so I could name them. It's a fun
That's okay.
trick, but
No.
it's okay. I'm not.
I couldn't do it either. Well, and we serve all counties. So some alignment there, right? And we already talked about for us, like our top values. And for definitely, I think, and it's, I can say like quality service, but I think for Camille and I, it is integrity, accountability, transparency. And we are both kind of no BS, both as leaders. and the way we provide services. We really fight for what's right. And I think that that would be another value that we share. So I just want you to think about who you are and then who shares some similarities, right? How can you? You know, I also get to serve on the Colorado Opioid Abatement Council, where we think a lot about collaborative. I'm always asking, how are we collaborating? How's that money being collaborated and how's it not being siloed? I'm huge about that. Collaboration is the better way. It opens up ideas. You know, for us, it's not always in agreeing either, by the way. I'm non-clinical. She's totally clinical. We have to like work on this. She's a clinical language. It's foreign to me. But we have to be willing to meet somewhere in the middle. And so you have to find some alignment with those that you serve, and it's easier to bear with one another. And especially with the way funding is and is going, I highly suggest it. So on this page 2, I asked for you to maybe identify, and you guys could do this later, but identify your alignment partners. And this is just something for you guys to think about. You don't have to do the worksheet. But I wanted to actually have you work today. I could sit here and tell you a bunch of fancy numbers that you will forget when you walk out the door. Or you can call me, I'll send them to you. Who are the organizations that you align with? Why do you align with them? What is it about them? You know, if I talk about like even Valley Hope in the room, Valley Hope and I service our area. We're both in Douglas County. I'm really a fighter to make sure that my community gets access to that treatment center. Like I will fight for dollars because it is a barrier right now. And I should be able to take my people in my county to that space. And so we have a lot of alignment there, even as an organization. And I'm alumni, so I might be a little biased. But no, it's true. We don't have a lot of that. And I have other treatment centers in my community that we don't have a great alignment with. Not that people blocks the service, go wherever you want. But when I think about the ones I'm calling, we're trying to think about something different. Like, how can we? I'm calling you, right? So I would put Valley Hope on this list. Tanya and I, right, get to do peer work across the state. We're both do training organizations. Tanya and I both are going to sit on the 5280 board. Along with Camille, there's some more alignment, right? So, and because we both remember, Tanya and I both remember being kids with no opportunity for education outside of traditional education when we were struggling. So there's alignment there. So who are the people in your neighborhood? In your neighborhood, in your neighborhood. Someone was gonna sing with me, I know you were. Do you love that? Okay. And then on the bottom, I kind of gave a broke down of alignment and not alignment. Where do you align and where do you not align? And if I'm being very candid, you know where we don't align? She's a clinician and I'm not. That's it. So far, that's the only one I figured out. You know, that's not an alignment. We can partner, and I'll tell you that from being a peer who works in a Medicaid world, it is not aligned. You're trying to make peers medical, and we're not. I'm going to be one of those ones that pushes against that. By the way, this is all the stuff that was in my head before I said yes to Camille. This was my brain process before I said yes. So kind of thinking back, like what surprised you? And the reason I had to do this is because as a peer who was a brightly shiny new person who didn't know anything about this world 6 years ago, Tiffany and I had. We didn't know. We literally were 2 girls from the middle, it felt like, of nowhere. And our community was drowning very fast. The phone calls were coming in faster than her and I could take them. And we had to do something different. And people saw that opportunity and took advantage of us. I never thought as a woman in recovery, if you say good people, you're good people, you're in recovery, cool, we run the same. Nope. And partially of what I had to do was kind of put some of my old skills back into use and go, girl, you better start reading people again. And I used some of my old skill sets and brought them into my present, and I started analyzing people a little bit more. And now am values driven. Hard Beauty actually will be the first in the state of Colorado. Actually, I think we'll probably be the first organization in the country to actually be values identified coaches and values driven and a value literate organization, because it's been so pivotal to the way we have shifted the way we work. I have to align. We don't have to agree on everything, but we have to at least align on some basic issues. And from those alignments, great things have come. The hospitals we work with, we have great alignment with. I have great alignment with Aviva. I get to do an amazing project for mamas this next year for a perinatal IOP project. Oh my gosh, I haven't even told you. I know, hold on. I know, don't get excited. No, do get excited. But yeah, we get to do some really good work because we have some values alignment, right? So I just wanted to talk about that, give you a chance to exercise and maybe put some thoughts in your head. Did anybody have anybody come to their head that they align with that you haven't even thought of? Nobody? All these smart people in the room. Okay, good. We'll be available afterward. Okay. Oh yeah, she said, I really am interested in talking to both of you. That means we did okay. We did good. We did good. Yeah. Yeah. Well, I wanted to talk, actually, we got a couple things. I forgot about the slide, sorry. So just to put some ideas in your head about who you would align with and maybe who you need to step away from also. So the other thing I wanted to talk about was our successes. We've had some successes and we've had some challenges. We can't act like, not all relationships are bliss. We have fun though too. I gotta be honest, I just need someone who doesn't take it all so seriously some days. And I'm so glad that I get to partner in this work with Camille, because obviously you can tell we don't get along at all. But our successes are, we have had a responsive partnership with the BHA, because what we're doing is quite revolutionary. They've had to rethink licensing. They might be irritated, but they love us because they know what we're doing is actually brilliant. I feel like it's a mini version of what they're trying to do. And I do get to know that because I also am the chairwoman on the Behavioral Health Advisory Council to the state. So, I'm kind of have an inside scoop. But it's been great because they've had to be innovative. The BHA's had to rethink this. They've had to wrap their minds around how do we do the licensing. And it's been great because they've been great and responsive. We have weekly cross-team meetings, integrated billing and supervision. So our teams meet every single week. They actually met this morning. If we don't meet, if her and I can't meet, they meet every single week. What's working, what's not working, what do we need to change? What new things showed up? That one right there. We'll get to that when we get to the challenges, because that feels like it's a lot. The success is a preservation of a workforce and program continuity, right? How many know about the MOMS program that Hard Beauty runs at hospitals? How many of you would be sad if it went away? Right? That program right there is because of this. And tangible impact. Hospital program sustained, families kept together, and mothers are maintaining custody. Win. And I think we get this and piece. I know for us, we didn't have somebody we would have said, hey, my client's not doing well and we need some crisis services. I don't know where that would have happened. And I love that we get to give that now to our clients. So like I said, I think we get the and. Our clients get that and, that and, that and, not this or this or. So I really love that. And it's easy to find. I tell everybody too, that beautiful ecosystem it's got a permeable membrane. You don't have to stay with us. But within that ecosystem are people that we all align with. We have to all align. Advocates for Recovery is also a part of that ecosystem. And all partners have to be in alignment. The challenges. You want to take this one?
It's my favorite topic.
I knew you'd love.
I think one of the challenges, right, is just the admissions process and all the administrative sort of documentation. I think we're going to see more and more of it actually because of what's happening at the federal level and because of changes to Medicaid. We get an audit probably a month from A-RAY or Medicaid or the BHA or, right, some other entity. We just got one from Labor and Employment for Fundsy this week too, just to layer it in. But I think that the behavioral health industry as a whole has a ton of sort of oversight and administrative burden, and there's not a real sort of easy way to get people into care, right? You have to do a ton of paperwork, you have to do a ton of extra stuff. And I think that's one of the challenges, sort of trying to take what is a pretty clunky set of rules and overlay them in a way that allows us to get people into care really quickly and easily without sort of a full interrogation. That's what I'm calling clinical assessments right now, because I think I'm funny. But it's a whole lot of questions that folks sometimes just really don't have the bandwidth for. And so we're trying to really think about how do you iteratively break it up, maybe send out modules and let them sort of self-report so it gets incorporated. But we're trying to really think about how do you streamline that? Because it really is tricky, especially for folks that are like, look, I'm at the end of my rope, so to speak, and I really need some support. And when you come to a system and all you get is a bunch of questions and you don't actually get an intervention, that's a real challenge for me and for them. But it's really annoying to me that we can't just provide care.
Yeah, I would agree. Could you imagine you're in having a baby and all of a sudden I'm like, so I gotta ask you some questions really quick, right? Like, can we make the baby the priority and let her have a birth and all of that? And then that's a challenge for us. And when we add Medicaid for peer services, Medicaid is a giant headache. I'm just, you know me, I'm not going to probably BS that. It is the hardest thing because you are asking people to do clinical work with not clinical pay, doing DAP notes and assessments and making sure the ISP coordinates with the goal. I'm a peer. I just want to go help her. And being if that reimbursement rate is the lowest on the pay scale. That is a lot of work for some of my staff who didn't go to high school or college and got their educations in jails and prisons. Like, what? And I'm pushing that Medicaid become more peer friendly. It's just not. It is such a challenge to employ, to train. It's a lot of work. I love it. I love that we've gotten to do it, but I think it is a barrier, is that Medicaid piece. And they've made it that I need it or I can't survive. So I have to, bow down, do the assessments, and help someone who really just needs, it's challenging for me. Believe me, HICPUF's heard from me quite a bit about it. Because it is a challenge. I just feel like we're just taking away, and peers were supposed to be the option before the clinical piece, before you get super technical with all the assessment stuff, we were supposed to be able to just show up. And that's not happening for us. We have to make it really complicated. And you've made it that way is the only way we can live. So we kind of have to bow down to the man, so to speak, and do it. All right, there's my soapbox of administration. And that's where it's challenging for us because they're clinical and we're not. And the amount of changes that my organization as peers, who some of them are 4 years in recovery or still having things, like that is a lot for them to take on. It is a massive amount of work. And it's a lot, even for my staff who are helping them make it through it. And we're doing it anyway. Challenges, the EHR and technology alignment, we got to figure that part out. I spent after getting robbed, we became hyper independent, good trauma response. To being robbed, actually, Hard Beauty, I tell everybody, is actually last 2 years is a trauma response to being robbed. We had to figure something out. And so, but we're really good at making beautiful trauma responses as people in recovery. I think that's kind of who we are, is a beautiful trauma response. And We built our own EHR system. We are actually built, yeah, right. I didn't even know how to build email 6 years ago. I was a stay-at-home mom on welfare, and I built an entire EHR system. What? We did. My team is brilliant. I didn't build it. Sorry, guys, I didn't do it. I know it was all you. But they built an EHR system, and so now we have to figure out how to get that to integrate, because our EHR system was built for peers. It is not clinical. It's customized for us. We found a wonderful developer who built it for us. We actually are completely HIPAA compliant. It's why I can work at Denver Health Hospital. We had to do that to learn how to get like completely HIPAA compliant EHR system. Otherwise, I can't work with hospitals. So we have to clear hospitals. And now we've come together. So now we have to figure that part out. How do we get that part processing so that she talked about it earlier, that continuum of care. How do we make sure the ROIs are going through? How do we make sure, make sure that that is really nice and tight? So that's part of one of our challenges now. My team is really struggling right now with all of the training requirements through the BOSO and the OwnPath and the We calculated this morning, my team told me it is 30 hours of training for licensure every year per employee. 30 hours. Oh my goodness, that is so much time. And most of the trainings aren't available that we need, and it is not peer friendly. So as somebody who advises the BHA, I'll be making some suggestions about that.
Can I say one thing
Yes,
about
absolutely.
training is sort of there's also, right, I think sort of silos within sort of organizations, state agencies specifically, in which, right, like there's requirements that on our crisis team that we have peer support professionals working. And before you can start doing crisis work, you have to take a whole set of required trainings. I think it's about 40 hours. But then there's also the peer support criteria, right? We have to get everyone certified. So we're like looking at 70 hours of just training to get our peers. And so really we're sending out messages to the BHA to ask, right? Like, is there some crosswalk of these two sort of required sets of trainings that you can sort of check the boxes so they don't have to do all the things? There's a ton of redundancy and a ton of duplication that's not really very elegant. And it just adds sort of stuff to our plate. And with each little program and with each little requirement, I know it doesn't seem like a lot if you're like a subject matter expert at the state agency, say, looking at your like sort of piece of the pie. But when you add up 72 pieces of that pie, it is a lot. And it becomes really unwieldy and difficult to track and manage as an organization. And right. And then when you start blending multiple organizations, like it's sort of compounding. So we're trying to think through that and try and orchestrate something that's somewhat elegant.
And we also have organizations like advocates that already do this training and like support work. Why are we like recreating the wheel? Why don't we just partner with the people that are already doing that instead of trying to have everybody go through this again, right? This government pathway, like you're going to come through my pathway. You're going to go through this one way. I'm like, oh my gosh, I don't want to go your way. I don't want to take your training. I actually would rather go to Advocates for Recovery. I'd rather go to Hard Beauty. I like let people make choice as long as they submit, who cares? But to me, it feels very ego driven so that the credit goes to them. Okay, I'm done. This was my question that kind of came up, but does the level of oversight improve outcomes or just slow access? Like, I mean, I am not somebody, I don't mind doing what I'm told. I used to be someone who did not, so I've come a long way. But I'm willing to, but is it really helping care? I can't, I have to say no. It actually reduces the quality of care by having all the oversight. And the reason behind it, I keep hearing when I get in these rooms is, well, because someone has to watch it and someone has to, I'm like, micromanage it or whatever excuses they have. But nobody at the national, and I was at the opioid conference last week and I spoke candidly about like, who is helping you make that decision? Do you know what that looks like on the ground? Do you know what this little line item right here looks like in the real world? No, they didn't. I said, put me at the table. Get somebody who's actually doing that work to help you actualize this in real time and what it looks like and the impact on the ground, right? Because if you thought about that, if I just took you through a day with my girl Daisy, Daisy's the mom I always talk about. you would see, if I took you through a day with Daisy and inserted all of these things, you would see why Daisy decided at one point, you know what her plan was? Her plan was to go have her baby in a tent, not at University Hospital. That was her plan, right? Because of all these other things that we've got to get done. She don't want to do that, you know? So I just want to think about that. And then, and the last one was not supposed to be the same thing, but I think challenges for us were, it's time, bandwidth. That's everybody's problem. And then I think ours haven't been internal. That's been nice, right? Getting our teams together. Any other challenges you can think of? No? So this was earlier. But when we collaborate, we don't get an enterprise, we get an ecosystem, right? Because an enterprise is by one. An ecosystem involves many. And most people won't do it because guess what? It takes a lot of time. We have to have conversations that are uncomfortable. I have to put my ego at the door. And the ego at the door, I think, is really the biggest strain I see to collaboration. I have to be willing to say, okay, Camille, I might have to give up this beautiful, brilliant, I might have to consider something different than the HR system in. And, that's hard for me. But if my common goal is quality care and outcomes, then I have to be willing to compromise. And so listening deeply to one another, I think is really important. And being willing to be innovative. I mean, we are both willing to do something that it just hasn't happened before. And it does make it a lot easier with like a fun partner to do that with. Any last minute things? Any questions? Mhm.
I'm used to someone bringing me a microphone.
Here. I was like, am I running? Are you running?
I am all about collaborating. For those of you that don't know me, my name is Corrine Johnson. I work for a nonprofit called Young People in Recovery. The ecosystem, I'm all for that. I picture that cartoon earlier this morning where it was like, who wants change? And everybody rose their hand, right? And then it was, who's willing to change? And nobody rose their hand. And then it was, who's going to stand up to make that change? And I see you, you're standing and you're willing and you're ready. And I'm telling you, so am I. And let's keep these steps going. So my question is, what can we be doing to work together? Let's start those conversations. Let's sit at those tables. I'm willing.
Yeah, get that list out and make the connection, make the coffee, have the time. Get to know each other's work, deeply know each other's work, right? And then ask how you can benefit one another. It's not always how it can benefit me, but how can I help you? I just had John, where are you at? John came up to me today and asked me a question. And I said, John, I need more information. We're going to spend at 8:00 next week in the morning. I tried to get him at 5. He told me no. I'm an early riser. But I said, hey, can we spend some time on the phone real quick? And just walk me through what you're doing so I can know it better. So I could maybe give you some insight and give you some feedback if that's what you're looking for. So spend the time, be willing to ask.
Thank you very much, the two of you. Round of applause.